Thank you so much for joining us. So excited because we want to share what we're doing in the southeast corner of British Columbia. We also want to hear how it impacts what work you're doing, what the synergies are, what excites you about this work, because it's incredible opportunity to get better and better at doing this work. So it's our absolute pleasure to be part of this. Absolutely, such a privilege to be part of working with Jared and Elizabeth, and now also all these bodies to basically think about how do we do this. So please, it's pretty much an open mic. We're going to look for themes coming out of the chat box, and we're looking to pretty well share something that we're very passionate about. I wouldn't say it's close to our hearts. It is our hearts. It is our passion. And it's something that we started long ago being passionate about. And then sometimes it drifts away from us when we start learning other stuff that often clouds. How did we start? What is important for us to actually understand about ourselves and each other? So I want to just share a line with you that kind of pivoted me, and I'd love to share the story later on if there's time and if there's interest. I'd love to continue the story, kind of weave it through our hour together today. This lady, 90 years old, with her husband of about 90, she stopped me and said this to me: "Talk with me about living. We all die at the end of living." And, I had been selling her a product, my product from healthcare, as advanced care planning or medical orders of scope of treatment. And she said, "Wait a bit, talk to me about living." And that stuff will take its place. It will fall into place because at the end, I will want to have lived die at the end of my living. And that has been such a revelation for me. It often changed that really awkward, difficult situation of how do I talk with this person about a difficult conversation to, hey, what do we need to talk about? And it's literally changed everything for me. And it seems like such a situation that we've got ourselves down the line of, we won't talk about it until it's too late, and then we'll try and pull it back. So this is our learning objectives today. We would like to suggest that you think about using what matters to you, not only asking the question of other people, but ask it of yourself. Because if you recognize the passion you bring, that's the start of literally an echo. Because if you understand what drives you, you can ask someone else what drives them, what will make it important for them to have the next best 1 year, 6 months, 1 month, 1 week, 1 day. It's literally, as we share an hour today, we can share journeys that literally last as long as they need to. And it's the type of question that you can practice at your supper table this evening. It's something that's you can ask your child, what would be good about having a really good summer? What would be important for you to have a good summer? What would be important to have a good soccer game? Pretty well, you can adapt this question to the person and the life that basically brings two people closer together, one deeply curious and the other one able to backfill that curiosity very dynamically. Understand that treatment is a process and care is a feeling. So what does it feel like when we actually recognize our feelings and be able to live with them well enough to actually get that empathy of what does it feel like for this other person? Jared's going to do work in that in a little bit now. And very important, no one knows me as well as I do. No one knows any one of the 37 people on this screen as well as that person knows themselves. And it's literally as easy as asking folk, what do we need to talk about today that would give us this better course, this journey together? Because we can journey together when we can walk next to each other. I can put my kit bag of doctoring stuff on my back and walk with someone as a person, and then just unpack what I need when the need arises. But then it's not like, I think you need this now, because that becomes a burden. We want people to recognize that they can ask for what they need, and I can do the same because it's It's a relationship. Next slide, please. So this is what's really exciting for us is sharing our projects. I've read, I'm part of Pallium Canada in terms of LEAP core facilitation, also part of Sarah's illness conversation. But this is something that tries to pull stuff together to say, what would it look like if we were actually actively planning? So our hospital at the moment is 137% over capacity, or 37% over capacity. And what would it look like if people had actually spoken to people as people 2 or 3 or 5 years ago to what would happen now for our hospital, our acute care? Folk that don't want to be there could be potentially somewhere else with different setup planning and stuff like that. It's also important to recognize that we can do this work very dynamically. It's super important to recognize that difficult conversations arise because they're often delayed, they're often deferred until there's a crisis. Now we're trying to do burning house conversations of, oh my word, how do we take someone off a ventilator? Stuff like that, when we should have had a conversation 2, 3 years ago that organically morphed to something quite differently. Then very important, we do support tools and stuff like that because providers often are uncomfortable having conversations where they don't have a support or a skeleton structure. And these tools are literally to be able to ask, you are actually the person, you are the main tool, you are the focus. It's not about the tools or the serious illness conversation. It's actually about a story. Your story becomes our story, becomes a better journey. Next slide, please. So in the chat, we'd love to surface, what have you done in your work? Where are the barriers? Why isn't advanced care planning everywhere? Why isn't it on charts everywhere? I'd love to see the chat box fill up with stuff as we go. I'm going to just ask Jared to reflect on what I've said. He's going to be taking over the mic in about another 5-10 minutes. Is there anything I've missed out while folk are working on surfacing stuff about advanced care planning, Jared?
I don't think that you overlooked or missed anything, Greg, but I just think it's important to recognize that, what we're talking about is empowering people, right? And we are leading this project, and leadership is about empowering people. And I think that that's important to recognize as we go through this work, that we're empowering individuals both personally and professionally to exemplify and articulate what health and wellness means to those individuals and how that relates and translates to end of life care. And if we can empower people in conjunction with equipping folks with the tools to be able to navigate certain scenarios or to better assist, the patient provider relationship moving forward in that empowerment and through this project and through this work, then I think we have the ability to impact and benefit future generations in really meaningful ways. And so thank you for prefacing the discussion, Greg. I think you did a fantastic job, and just looking forward to seeing how the rest of the conversation goes out. And when it comes to, my portion of the presentation, I will do my best to fully articulate, what treatment versus care looks like, what that means, and again, how we can empower people to assist us in allowing them to go through this part of their journey gracefully, but also at the same time, again, just that reoccurring theme of empowerment. So thank you very much.
Thank you. I'm really hearing that word empowerment come through. Elizabeth, what are you seeing in the chat that says, hey, you know what, this is a theme that we're seeing from all 40 people now. What is something that would be coming through there for you?
Yeah, I think it's in line with what we've seen elsewhere too. People don't want to think or talk about death, and there's many reasons that are coming up on why they might not want to, cultural, religious, language, and I'm sure many others that we're not aware of. The other comment was about time, right? And the time it takes to have these conversations, and the feeling that will take longer than it maybe needs to if we start early enough.
Yeah, absolutely great points. And the thing that I really love about doing this work, where there's energy, there's place to engage. So we'll talk about this as we go through, but a person that actually says, hey, doc, I want to fight this. not ready to talk about palliative care yet. I love that, because now you can actually say, George, tell us what a good fight would look like. Tell us, I'm listening. And you can literally add to that. What else? What else, George? What else? Because you are not changing the course of their heart failure, their chemo and stuff like that. Besides for following, okay, there's X-rays and CT scans and all that, but you can step into next to the person. Don't say, oh my God, you are dying. You really have to hear that. Partner with them to say, what would a good fight look like? What would it feel like to be able to do this or that as a goal for 1 week or whatever? It's a different take. Anything else there, Elizabeth?
Yeah, I think there's a lot. I mean, there's a lot of great examples, but I think the core themes are there. The clinicians, providers also have their insecurities and familiarity and experience with having these conversations.
Yeah, absolutely. Next slide, please. I think one of the things that if we don't leave you with a sense of being slightly scared of like, what are these people talking about, that you can actually pivot to just being in the moment with someone who's usually scareder than I am, more scared than I am, to actually say, hey, we're both feeling it a bit. How do we actually feel better by basically working with what we got? What was yesterday like? How's today going? What would a better tomorrow look like? And then just being there for listening to that answer. And that's what really is about. Talk with me about living, because we all have experience in that. We can do that. A person can very well say, well, you know what, doctor, I'm scared about what's happening to me. And then you can pivot into that serious illness conversation of, wow, what do you understand about what's going on? What do you understand about your cancer, your heart failure? But once the person has opened up their mind door to, this person is curious, this person isn't selling me a product, they are interested in my problem. And that way they open up a mental door to say, they're listening to me ask about my shortness of breath or my experience of cancer or why I didn't sleep well last night, without judging it, without literally just saying, what kept you awake last night? Because I want to be with you so that we can work on that together. And that often eases in stuff like opiates and all the other stuff we often battle with. If we come at it, you need this, is very different to say, what would it feel like to be able to walk with your dog again, even for a short way? What would it feel like? And that becomes very much more organic. Next slide, please. So this is unfortunately my experience of how I learned stuff. I was taught about pathology. I became a pathology expert. The What Matters to You program literally came about because two people looked at the question that medicine is often all about, of asking, what's the matter with you? What's your complaint today? It's about pathology. And they flipped that to literally say, what matters to you today and going forward? What matters to you? Because we are not pathology. We are vessels that are far bigger. We're part of a bigger community. We're part of families. We stuff like that. Often there's mothers and grandfathers, and often I read an obituary and say, oh my word, I wish I'd known more about this person when they were alive, because I would have been able to understand how their treatment and their requests had actually fitted with their lifetime story, because that's who they actually were. If we can upstream that to 2, 3, 5 years upstream, we see more of that full person and how the pathology relates, because we know that we can decrease anxiety, depression, and all that stuff, but we can actually give a much better story, and the person can sometimes even live longer than expected, because we've actually recognized that the person isn't their cancer. It's not their kidney failure. They're a mother, a grandmother, a mentor for family members, and all that stuff. So look at story, look at it richly, dive into it. Don't be scared of it. Time honors time. So this time you spent listening to a person will come back to you later on. It always does. 2 or 3 admissions is an incredible long time in a person's story, and a lot of medical time and resources. We actually listen more time invested becomes time saved. And it's also fantastically supportive for the ties that people have, not as patients in our medical system, but as people in the world that we all share with them. So frailty isn't a weakness. It's part of who we all are. And if we accept that as like, how do we actually accommodate that because we're curious, that changes everything. Next slide, please. So listening to a person is very different to listening to a patient. Very different to listening to a patient. A patient, that's a pathology focus and stuff like that. And I, as a physician, I am on the same journey. I can learn an immense amount from someone else who is 10, 20 years ahead on this. And I actually get quite, I suppose you can say, afraid when I read stuff in our literature that says educate the patient. I believe and I feel that we can pivot that to how do we learn together? How do we learn about stuff? I'm fortunate today to say I don't have pancreas cancer, but the person who I see with pancreas cancer can teach me so much about pancreas cancer, even though I've seen it from many other people before. They can tell me what it's like to live their previous life to today and what needs to happen next, because there ain't a plan for that yet, but we can make one. And that goes back to the thing, since pivoting to what matters to you, what is your story? What is your best next month, best next year? You can actually get to the point where you can say to the person, when it's your time to die, what would that look like? I have not had any person ever say, wow, I'd love to be in ICU. Please intubate me and don't turn me off for 2 months. It pivots everything to basically the thing of open question. Basically, tell me a story and I will be able to backfill that of saying, how does this fit for you? Because now I understand a bit more of your story and we can change that as your life evolves. Because I've heard myself asking people, do you want your heart restarted? Well, I mean, what's the context on that? I don't know. I don't know how to answer that now myself. It could be yes, it could be no. And then we get angry with ourselves for having asked it or for the person giving the wrong response, when it's a story of context and it's the evolution of two people developing a relationship with who they are and what the resources and system and their family is. Next slide, please. So this is my favorite slide, and it's something that kind of tries to pull it all together. Basically, story evokes emotion. Emotion changes story. Feelings change story. It's not about me saying, you know what, only 5% of people with pancreas cancer live this long or that long, because I don't know if they're in that 5% or not. I also know that pancreas cancer is very deadly. So is life. We all die at the end of living, as my lady literally said, you know what, I'm entering you in this. We all die at the end of living. So basically, for me to actually talk about, wow, we really need to talk about this, we can flip that to say, actually, what's important for us to talk about today? Because that way we can actually change our stories by actually listening to each other and then developing a new one. Story is changed by emotion and feelings. It's not by me knowing something and telling you or educating you. That is something we really want to leave behind as a person-to-person dialogue in a journey of life together. I can unpack my doctoring stuff when they say, wow, I need this information, or what do you think of that? Or doctor, what would you do? Because that often ends up when trust starts evolving. And that's the next thing. Trust and time travel together. That doesn't mean you need to spend lots of time doing this, but start a lot of these discussions with, what do we need to talk about today? Be comfortable with the silence. And then ask, what else? And what else? Because people are amazing. Jared's spoken to that empowerment and resilience piece. I have often been absolutely blown out the water by someone who said, you know what, that patient doesn't want to speak about this yet. And yet when you speak with them about what they do want to speak about, they'll unpack all kinds of stuff that actually says, you know what, I get this. It's just in a process in evolution. Don't be scared of investing time with questions that basically push the elephant out of the way, that's deeply curious, connecting, and respectful. It's time invested. We have not yet get brought in trauma-informed care into this work so often, and this is in this space all the time, of the person needs to talk about dying. Damn it all, they need to talk about dying. They haven't got there yet. Well, how many of us, as a previous paramedic in South Africa, I saw people dying in the most terrible ways. I have nightmares sometimes about people. If I had no other context to this work, I would say, I don't want to do that. I want to not do that. End of story, door closed. We can come from the point of, what do we need to talk about today? What has your experience been of this work before? Let us talk about those. If we can bring in trauma-informed practice into this work and actually talk about what needs to be spoken about, because we're all going together on a journey together, and that trauma can be brought along and be hauled into the plan as we go, it changes everything. And that's why I so love this lady telling me that even with 180 years of combined experience of these two people living together, they wanted to talk about living because they pretty well had a lot of stuff and a lot of resilience that they could fall back on and say, you know what, back then in the war, when I was a soldier and all that stuff, you know, between the two of them, they had all kinds of stuff going. So feel very comfortable acknowledging the conversation that needs to happen with a trauma-informed lens. They don't have to talk about dying. We'll get there in the end. I promise you, there's no one that gets out of dying just because we have felt that they need to talk about it. The neuroanatomy is absolutely amazing. So brain stem stuff makes us fight or fly or fawn. So that's basically, you know, the little deer that tries to hide away because its mum's away, or basically the fight or flight is the mama bear sort of thing where that's going to protect the cubs or go up a tree or whatever. But that's in us all. If we come where a person is scared, they haven't slept, they're not eating well and stuff like that, and we lay a discussion on them that's terrifies them, keeps them in their brain stem region where their neurochemistry is literally about adrenaline and stuff like that to stay alive, we are not helping their bid to actually be healthy. We can come at it from the literally what matters to you question that says, come up the stairs, come up the brain stairs all the way to the upper areas where your library of information lives. Come up the stairs, here's my hand, come up the stairs. Tell me about what matters to you, because you coming up the stairs and us developing a plan where there's a lot more information helps you not have to live in the brain basement of fight and flight and hiding back there. Come up here and live with everyone else, because we will listen. We will listen and we'll keep on being curious, and we'll add to that on your terms. It'll be one of the best experience you'll ever have. You know what? You started thinking about that last time you're in. What's important for us to talk about now? Next slide, please. Okay, this is over to you. And as we kind of transition, I think this is over to you, Jared. Have you got anything you want to add to what I've been talking about and transition into where you're at?
Just to complement, what we're talking about here, especially around, that trauma-informed aspect is, when being trauma-informed, we're then transitioning into the conversation around cultural safety and cultural humility in the process, right? And I think that is something that we can highlight and that we can recognize. And over the next couple of minutes here, I'm going to do my best to try to capture that thought and to be able to make it as impactful as we can in this short amount of time, because the reality is that, when we're talking about this work And when I first started coming on board with this project and, started working with the healthcare system, started to realize that there needs to be a differentiation between receiving treatment and receiving care. And I think that Western medicine has done a job of amalgamating the terms, inadvertently and indirectly. And I think that there needs to be that differentiation. And I think in understanding that, we can then better assist people in transitioning from health and wellness journeys into end of life care. And so, you see the chat box question up on the screen there, and I'd like to turn the page. If we can go to the next slide, we can then start having the conversation around receiving treatment and receiving care, right? Because I think it's important to recognize that as professionals and as providers, we're equipped with the tools to, navigate these sort of situations, to analyze the situation, to try to make some recommendations and some suggestions that we feel would benefit the patient. Ultimately, inadvertently and indirectly neglecting that patients will always be the subject matter experts on themselves, right? Patients will always know what allows them to feel safe, what allows them to feel like they're being empowered to make decisions toward this end of life transition, right? And so just turning the page, right, and having a conversation around treatment versus care. So if you could go to the next slide, please. Important to recognize, right, that when we're doing this work and when we're taking this into consideration, that cultural safety and humility is important to recognize when we're unpacking treatment versus care. The understanding that cultural safety is mindfulness and awareness that people of all races, religions, backgrounds have values, beliefs, and perspectives that pertain to the individual, right, and pertain to how they were brought up and their cultural background and the intricacies and the sensitivities that surround them as people and as human beings. Humanizing conversations, right? And I think that, there are times where we focus on the data and we focus on the analytics and we focus on the treatment. And sometimes in that, we sometimes neglect humanizing the conversation, right? And it's no slight on any one individual, right? We're doing our best to assist individuals transitioning into end of life care. However, if we have a difficult time humanizing conversations, the patients will know that, right? The patients are coming from a place of trauma, unfortunately, in some of these conversations and in these moments. And I think that we recognize as human beings that, traumatized people, they hear so much more than the words that are coming out of your mouth as well, right? They also sense tone inflection and they sense body language and they can sense when we're not being genuine or when we're hesitant or we're resistant, right? Which, kind of leads on to the next slot of, how we show up for the work is critically important, right? And if we show up hesitant and guarded and resistant and defeated, we're probably going to be met with hesitance and uncomfort, disconnection, disengagement, right? And so how we show up as professionals and as providers will be critically important to the work that we do. If we show up in a manner where we're forward thinking in a sense that we're willing to empower individuals to allow them to make decisions, if we show up in a manner that is conducive to walking alongside individuals in their journey, the patient's going to recognize that, right? And they're going to recognize that. Not only are they going to recognize that, but I think they're also going to find a deep, profound appreciation to the professional and to the provider in that work. Understanding that, when it comes to empowering the individuals that, again, as subject matter experts on themselves, only they know what's going to allow them to feel culturally safe, what's going to allow them to feel personally safe as they articulate and define what their health and wellness journey looks like to them, right? And in that articulation of health and wellness journeys, understanding that journeys do come to an end, that's when we can start having the conversation around transitioning into end of life care, right? And in that, conversation, somewhere in that thought, we also need to capture, this concept of rights versus responsibilities, right? Because there are times where if we're showing up ineffective and we're focusing so much on the conversations that we may or may not have the right to talk about, or the questions that we may or may not have the right to ask, inadvertently we overlook our responsibilities, right? We have a responsibility to inform ourselves. We have a responsibility to educate ourselves. We have a responsibility to empowering clients and empowering patients. We have a responsibility to show up effectively so that we can walk alongside individuals as we transition into end of life care. And so that concept of rights and responsibilities is important as well, because, if we're so focused on what we may or may not have the right to discuss, or what we may or may not have the right to ask, it's easy to overlook the responsibilities that we do have. Right. And again, no slight on any one individual or any one organization or any one unit. It's just, sometimes these are human emotions. And again, we're humanizing the conversation, right? We're allowing ourselves to humanize the conversation. And in that comes an aspect of humility, right? And understanding how we're showing up, and understanding our rights and responsibilities, understanding how we can empower individuals to articulate what cultural safe care means to these individuals, or what cultural safety means as we transition from health and wellness journeys into end of life care. And so when we're having these types of conversations, in the education, in the responsibility to provide accurate, relevant information pertaining to healthcare, when that is achieved, right, we can then understand how we can make that relatable and translatable to treatment versus care, right? Understanding again that the professional or the provider has the knowledge and the information that speaks to treatment, but understanding that the patient will always be the subject matter expert on themselves, and only they can articulate what care means. And when we can balance treatment versus care, and we can balance rights and responsibilities, I think then we're working toward empowering both of us as professionals and providers, but also the patient and the client, to articulate what this journey means for us together and how we're going to get there, right? None of us is as smart as all of us, right? And when we have the ability to put our heads together, to put our minds together, we have the ability to impact change in really beautiful ways. And the best way to do that is for us to empower ourselves and allow the high tide to rise all, and allow us to come together as professionals and as patients to be able to fully articulate what health and wellness journeys means, and also how we can transition into end of life care, and allowing individuals to pass gracefully, empowering individuals to make those decisions. Ultimately, in the end, allowing individuals to feel like they can take control of the situation, right? And I think that that's what's important in this work, is how do we get there, and how do we provide that sense of safety and foster that type of healthy environment for growth, right? And just knowing that it's end of life, and knowing that, ultimately the journey is coming to an end, we still have a responsibility, and we still have a responsibility to ourselves and to our patients, right? And I think when we're taking all that into consideration, we understand treatment versus care, right? And we're differentiating treatment versus care, but we're also not neglecting the onus that we have collectively in transitioning into end of life care. And so I think I can leave it there for now. Ultimately, we would love to continue the dialogue. We would love to know what matters to you as professionals within your respective boundaries, within your respective communities. We would love to hear more, poke and prod and ask questions, and think provocatively about how we can empower ourselves to show up effectively to have these conversations. And equally as important, how we can show up authentically to be able to humanize the conversation, to be able to balance treatment versus care, to balance rights versus responsibilities, right? Because there's so many emotions that come attached. And if we can humanize the conversation and focus on where we align, as opposed to our differences as people and as human beings, the conversations will get easier. The relationship will continue to blossom organically, and we can empower each other. So I'll leave it there for now, Greg, and just pass it back to you for.
Yeah, thanks, Jared. I'm seeing a lot of very rich contribution from the chat, and I've answered Valerie, but I can't get to everyone, so I've kind of got quite a bit of dyslexia going. So if you feel you've got a pressing question, feel comfortable putting it in the chat, or even unmiking and asking us, because it's super important that this becomes a what matters to you. And I don't know if this is intrinsic, or this what matters to you question is something that there's a program in British Columbia that's basically, I guess, very well supported by Health Quality BC. And there's beautiful videos and beautiful shorts and support tools and all sorts of stuff. And so it's not something we're just talking about ad lib today, that there's actually a lot of depth, a lot of research, a lot of rigor that actually says, if we start early and we keep on asking and we keep on adding, okay, this is new information, and how does that go with what you've told us about what matters to you? It doesn't become like, oh my God, this is the last month of your life, because statistically, that's what is currently happening. Currently, people are told within their last month of living that, oh dear, we've known this for quite some time according to your file, your kidneys, whatever, but now you're in hospital admitted. So imagine all the time wasted. Person wasn't having fun until then. They were actually often battling with stuff like symptom burden and distress. They were often battling with issues of dignity, of getting to the washroom, of burning out caregivers and all that stuff. But now they're kind of in the last lap. So we literally want to say, what would this look like if we actually started this question 2, 3, 5 years at your kitchen table tonight? So it becomes part of our culture of really caring deeply and really supporting someone with increasing frailty. So that's physical, mental, or both, being able to be part of their people, their traditions, their culture, because our medical culture respects, honors, and adds support for it, not replaces it. Because the folk on our third floor in Cranbrook at the moment, I could guarantee not one of them would say, I want to be here. And yet, none of them, or very few of them, have had this discussion 2 or 3 years out. They're busy having it in crisis now. And I see from the chat box, that's the experience of many of the people. They say, oh my God, I wish in my job as counselor or social worker and so on, I wish we had more time for it. And we're asking, make more time for it by investing in each other longitudinally, so that it doesn't become about hospital beds and IV supplies and intubation and a number of ICU beds, but much more about what the person wants. Because I believe with empowering people, as Jared said earlier, we can do much more of this work in their story and not in the medical story. So what have we learned from past history? How do we move that into current history so we learn from history and don't sort of keep on stepping in the same potholes of not honoring people's situations, families, beliefs? Because we change with time as people. We all become more frail, and that's something that we can talk about early if we ask about it. What else is coming up? Elizabeth, what do you got going on there? Esther, how are we doing for time?
So we have about 12 minutes. I just wanted to say, if anybody wants to speak to the content, you are welcome to unmute yourself if you have a question, or pop it in the chat so we can navigate that. Both Greg and Jared have downloaded and shared a tremendous amount of insight and information. We want to hear from you. Are there barriers, perhaps, that you keep hitting? Are there situations of hope? Are there tools that have been important? How has what matters to you been a change agent in your practice, working with persons?
Valerie, do you
We
want
do
to
have one more
unmic?
slide
Because you,
too. If we want to pass the slide over, we did have a prompt question on the next slide.
Valerie, while we're looking at that, you've asked such good questions. You've you've reflected so elegantly. If you want to unmic and just share that for all 35 of us, all 40 of us, or whatever, I'd love that.
Sure. Thanks for the invitation. So I'm a hospice palliative care nurse practitioner in Kingston, Ontario. So I go out and see people at the end stages of their life-limiting diagnoses when they're no longer able to get to other care settings. And I just shared an example of what I frequently run into, which was yesterday meeting a gentleman for the first time who's actively dying at home, PPS of about 40%, but has declined over the last couple of weeks quite drastically, who really deserves to have this type of approach, and unfortunately has not had that opportunity. And my visit yesterday was really about getting a plan in place to support him to stay at home for as long as possible, because that's where he wants to be. But the realities of his situation, of being alone, of being in a not very well controlled as far as people coming and going type setting, limits the things that we're able to do for him. And so it kind of feels in situations like that, and even in less sort of dire situations, that the systematic limitations of our healthcare systems right now get in the way of really genuinely asking that question and being able to do much about it. I feel very strongly about palliative care being about what matters to an individual, but when an individual tells you what matters to them is staying at home, and yet the amount of home care that you can provide for them is not even remotely going to enable them to do that, it seems a bit trite to ask that question. Although I recognize just asking the question means something for that person, but then it puts you as a healthcare provider, me as a healthcare provider, into a situation of needing to sort of backtrack. Like, okay, I hear what you're saying, however, and it feels like more and more that's the type of conversation that I end up having with patients, that the things that matter to them, the things that would be helpful, I can no longer provide, our system can no longer provide. And that's really hard. And I don't want it to limit my willingness to ask this question, but it is really challenging when every time you enter into such a conversation that you find yourself at that sort of crossroads.
Yeah, I really feel for you, and I recognize exactly where you're coming from. I also love doing home visits, and I think one of the things we are really looking at doing is getting this question to each other so that we can get this work done upstream, and not as like, oh my word, this person now wants to die at home, and now the planning has to fall on home care nursing and prescribers and nurse practitioners like you and I. But actually, what would it look like if there was more supports? Because we have not only asked each other this and our communities this, but we've also asked our health authorities this question, because that's one thing this program actually says. It's not about, this is literally about the bus drivers and the school teachers and everyone contributing to this, so that we get to the point somewhere in the future where it actually becomes like, wait a bit, what would it look like if we actually believed that that was possible 2 years from the next time you or I have to run into this situation? What would happen if we actually asked our health authorities, our provincial government now, to believe in what matters to you, so much so that we actually, instead of investing in multiple admissions, we actually said, what would it look like? What would matter to you and me and our government and all that stuff? To actually say, we understand that this person needs something different, if not now, in the future. Jared, what are you seeing?
Yeah, it's interesting because, I when I first got onto this project, and working around the conversation around palliative care, and I was flabbergasted and taken aback, right? Because as an Indigenous person growing up, we didn't have palliative windows, right? We didn't have times where we could, assist people and guide people through end of life care in this transition. Oftentimes in our communities, it's when there's a fall or there's an overdose or, something like that, because there's not a lot of attachment to the healthcare sector and to healthcare in general with respects to Indigenous populations. And we see that data all over the place, right? All over this country, that that attachment just isn't there. And so, the few things that come to mind, right, are what is important to individuals sometimes is, community, is family, is relationships, and how do we empower, those that are being left behind to assist this individual in transitioning into end of life, things like, sometimes you get hypothetical conversations that happen, if you had a minute to live, what would you do with your time, and those types of things. And like, even asking something like that, or just that thought-provoking conversation, and hear, the care that comes attached to the statement, right? And some people want forgiveness, and some people would like a hug, and some people would just like to see a friend or to have a conversation. And we can provide some of that as professionals and as providers. It might not be exactly what that person envisions, or the exact individual that they were hoping to see or be a part of that conversation, but we can certainly try to be a friend. We can be an ear. We can guide people through those types of conversations. And so I feel like, it's always going to be something that we have to adapt to, right? And it's something that is going to be unavoidable moving forward, that not every one individual is going to experience this. But if we can start mapping it out now, and for us as Indigenous people, we're taught to think very generationally. Right. And I know and I understand that the cultural safety work that I provide today, I and my generation won't be the generation that fully realizes the value and the benefits from that work. Right. I have an 8-year-old son, and his generation probably won't realize the full value and the benefit from the work that we're putting in today. But we hope that his son or his son's son gets to see the value and the benefits from the work that we put in today. And so just by starting this conversation and having this conversation, we have the ability to impact and benefit future generations moving forward in a really healthy way. And I think that your points are very poignant, and it's difficult to have an answer, or that one size fits all concept and that would benefit everybody. But I'm grateful, Valerie, that you were able to bring up, some of those points, because it allows us to know that, here's some things that we can be mindful of moving forward when it comes to palliative care. And we might not be able to address every one individual's unique needs. We can hopefully do a high level of service by trying our best to put things in place that are going to allow us to hopefully navigate situations like this moving forward. So I'm just appreciative of the conversation.
Oh, Rebecca, you've got your hand up. I just wanted to share while you unmute there. I had a patient who said, you know what, if I could die 13 times, I'd be really good at it by number 12 and number 13. And that's the thing. There's 8 billion of us on the planet now. And how do we move the palliative approach into this? So we talk about how do we live and age really well, so we respect each other, to be able to navigate the complete uncertainty that Jared's talking about, where we don't know how this is going to be, but we can give a person a hug if they ask for it. And there's nothing like seeing a grandchild hugging a frail, elderly, demented lady, and she smiles before she dies. She smiles before she dies because she felt something. So that's how do we take our treatment and make it what caring feels like. It's often just the feeling of a grandchild hugging you. Where did that hand go? I saw it.
It was me. It was Rebecca.
Rebecca.
Yeah. Can everyone hear me okay before I spiel off? Great. So I am a CRN at Canuck Place Children's Hospice, and I really appreciate Valerie's discussion about, lack of resources being a huge barrier in home deaths for people who would want that option over hospital or hospice. We in the previous years, Connect Place has seen that evolving a lot in the community, and the need for more community supports for families that are wishing for their children, and children wishing for themselves to die at home instead of coming into hospice, because that's, you know, where people feel safest majority of the time. And so that brought in recently we have started up an enhanced community care program through Connect Place. And that came from a lot of, you know, looking into funding, being able to establish that, because there was such a lack of expert pediatric palliative care professionals in the community to be able to do this work. So it started off as quite a small little group of maybe 2 or 3, and then now we have 5 CRNs and 2 NPs that run the enhanced community care program, and it is it's really thriving, and we're really busy, and we're doing a lot of education with other nurses in the community as well, and liaisoning with other teams, even adult palliative care teams that are willing to step in and enter into these children's homes and provide care with our help virtually and over the phone. So I have high hopes for this to also somehow evolve into the adult world. I just feel like I feel very strongly for people to be able to have their last breaths where they want them to be. So if that's at home.
Absolutely. Absolutely echo what you say. It's often amazing if we pivot, and it sounds like you're pivoting to what do people ask for and how can we honor their story. We're just getting messages from Melody that we have to round out. I'm so excited that we actually have to trip people at the wire because we were into this. Rebecca, I can't imagine how important it must be for kids because, oh man, thank you so much, every one of you, for joining us today. I'll hand back to Melody and Esther, and it's been such a privilege and honor to join you for an hour. Thank you so much.
Oh, thank you so much, Greg and Jared, and to each one of you who participated. I feel like exactly the same thing. There's much that we can learn. Thank you. Next slide, please, Esther. I just want to say wholeheartedly on behalf of the center, we appreciate your participation, your learnings, and everything that you've shared and contributed. Thank you, Dr. Greg and Jared and Elizabeth, for supporting us and continuing to inspire many, many of us who are across the province and continuing the work. You can connect with any one of these individuals by email here. I'm just going to go to the last slide. We do have 2 poll questions that will pop up to you. If you would have a moment, we would really, really, really appreciate your feedback. If the knowledge of today's level on topic today increased your awareness, and was this session helpful to you? And the second question then is going to follow then, does attending an ECHO session help you learn about supporting for people with a life-limiting illness from other organizations, services, and healthcare providers? Thank you for doing that for us. This is great feedback for the team who presented as well. And the last but not least, I just want to invite you on behalf of the BC Centre for Palliative Care for our upcoming 2nd biannual Altogether Symposium, which is October the 4th. Nurturing Partnerships and Reimagining Palliative Care, really timely, critical information and time to engage with other trailblazers, clinicians, researchers, healthcare administrators, frontline people like yourself, around how to bring palliative care, honor, and dignity to every British Columbian. Jump on our website and you can see more, learn more. The registration is open until September the 23rd. It's an in-person 1-day event in Vancouver. Thank you so, so much, everyone, and really appreciate your time today. Thank you for being connected. Take care, everybody, as we're signing off.